The focus of this presentation will be treatment outcomes of visceral leishmaniasis with HIV co-infection in Bihar, India, but a quick reminder before that, so we're talking about a parasitic disease which is transmitted by sandflies, with the parasite mainly localizing in tissue macrophages, predominantly liver, spleen, bone marrow. So this also explains the main clinical presentation of hepatosplenomegaly, pancytopenia, and as a chronic infection it's also present with fever and cachexia. Without treatment it's a lethal condition. In terms of diagnosis, on the one hand we can rely on detection of antibodies. We have easy dipstick tools currently available. On the other hand, we can also look directly for the presence of parasites in the macrophages, which requires tissue aspiration, either spleen, either bone marrow. So it's currently the gold standard diagnosis, but it's invasive. On the other hand, since antibodies remain present many years after infection, it's the only way to document response to treatment as a test of cure and to diagnose relapse. So for this presentation, we will focus on Leishmania HIV co-infection. So there's another factor coming in, the HIV virus, which, as we know, disseminates widely in the body, but also localizes in the macrophage. So they can actually directly interact with the parasite at the cellular level. There are a few issues related to VLHIV co-infection. So we think it's an emerging problem worldwide. Treatment is challenging, so there's high rates of toxicity. There's higher mortality. Treatment response is poorer, especially high relapse rate, and you need to provide ARV treatment to improve long-term outcomes. In terms of data available on co-infection in India, there's a huge knowledge gap, being aware that India has maybe 40% of all Leishmania cases in the world. But currently available, it's mainly case reports of VLHIV co-infections, short-term follow-up, essentially reporting very high mortality and very high failure rates. There's no documented experience with liposomal amphotericin B, ambisome, and there's no documented experience with the use of ART for these patients in India. On the other hand, based mainly from data from rich countries, it seems to be that the use of ambisome, liposomal amphotericin B, combined with HAART would be the best option actually in all settings. So this brings us to the study objectives, which are to determine the long-term treatment outcomes of co-infection treated with ambisome and ART in Bihar, India. So the questions we had was, what is the safety and efficacy of ambisome in this patient population, so co-infected patients in India? Currently unknown. What is the impact of a response to ART, also unexplored, and especially what happens in the long run? We know HIV, it's a chronic problem. Actually, you want to see what happens after 1 year, 2 years, and ideally even longer. So we have a treatment program, a Leishmania treatment program in Bihar, India since July 2007. And a key feature has been, since the launch of the program, to use ambisome as a first-line treatment for all patients. And the protocol, when it was developed, recommended 20 milligram per kg total dose in 4 doses, unless the patient had received a complete course of ambisome before and presented with relapse, then the dose was increased to 25 milligram per kg. So all patients were proposed after VL diagnosis to undergo HIV testing. So obviously for co-infected patients, ambisome was followed by triple therapy HAART. In terms of diagnostic workup, all patients had documented Leishmania infection, so tissue aspiration was done and parasites were visualized in the macrophages. The same was done after treatment to document treatment response. So patients failing there, when you still can demonstrate parasites after treatment, are labeled as initial failure. On the other hand, if a patient initially responds and presents later with clinical signs and the test is repeated and you can demonstrate parasites, we talk about relapse. So patients were monitored at regular intervals. There was also active patient tracings if patients missed appointments. So data were collected routinely from the start as a kind of program monitoring. There were data quality measures available, and all files were reviewed and double-checked with a database for this analysis. So For this presentation, we conducted a retrospective cohort study, including all newly diagnosed Leishmania HIV co-infected patients since July 2007 up to July 2010. And the main outcomes I would like to show you is on the one hand, mortality, death. On the other side, treatment failure, either initial failure after treatment, either relapse during follow-up. And particularly, we were interested in the long-term outcomes. What happens after 6 months, 1 year, 2 years? So the data I want to show you will show the incidence of these two outcomes over time up to 2 years using Kaplan-Meier methods. So we identified 55 co-infected patients, predominantly male patients, the majority migrant workers migrating to the big cities, presenting in general with low CD4 counts, and almost half of them had been undergoing VL treatment before. 8 of them had received multiple courses of VL treatment before. 5 of them had been treated before with Ambizone. If we look first at a few indicators of safety, overall we detected only minor side effects, so none of the 55 patients had to interrupt because of side effects. So overall tolerance seemed to be good. Only minor changes were seen in terms of liver or kidney function. If we look at initial indicators of efficacy, we observed, as expected, a clear increase in weight, hemoglobin, platelets, and a clear reduction in spleen size. But the main outcomes I want to show you are the heart outcomes, and since they're co-infected, you can look at it as a VL treatment program perspective, and you can also look at it as an HIV treatment program perspective, but we'll focus on the first part, the VL treatment perspective. So overall, we identified 8 relapses, so 14.5%. 6 patients were labeled or had died, which is 10.9%, although additionally 1 relapse case subsequently died during further follow-up. All patient outcomes could be ascertained due to active follow-up. So overall treatment success was 74.5%. There's a small typo there. On the other side, in terms of ARV treatment, the only thing I want to mention is that 50 of the 55 were initiated on ARV treatment. 5 were not initiated. All of these patients died, mainly early after diagnosis of VL-HIV co-infection. Overall retention in care was quite fair at close to 84%. But as mentioned before, the main interest we had was to look at the long-term outcomes. What happens up to 2 years and how does it evolve over time? So if you look first at mortality, which is the plot in black, you see that as expected, these are patients with advanced HIV, end-stage HIV. We have a phase of early mortality, but then it somehow seems to stabilize at 14.5% by 2 years. So 85.5% were alive by 2 years. On the other hand, if we look at relapse, so I have to mention we didn't document any single case of initial failure. So at least the initial response seems to be good. But if we look at relapse during follow-up, we didn't observe a single relapse up to 6 months. So you can see it there, 0% by half a year, 6 months. However, if we continue monitoring the patient, it goes up to 8% by 1 year and to 26.5% by 2 years. And we don't know how it will evolve. So important to know that standard reporting of VL outcomes stops at 6 months. So this shows that at least for co-infection, it's worth looking at the long-term follow-up. It's also raised the issues, can we somehow identify which patients will relapse? Or actually, are all patients at equal risk, or can we somehow target the monitoring? We didn't find any baseline factor which was predictive of relapse, in contrast to some other studies. However, what we observed was the CD4 count at 6 months, so reflecting the response to ARVs, was predictive of subsequent relapse. And just to remind you, all relapse cases were observed after 6 months. This graph suggests that if you have a clear response and you can increase the CD4 count to, let's say, 250, 300, the risk of relapse seems to be low in the next 6 to 12 months. Before we go to conclusions, I listed some of the limitations. So it's a retrospective study, small size, no control group. But just to remind you, what we have up to now available from India is mainly case reports, short-term outcomes, very selected patients. So I think it still adds to what we know up to now. We didn't have complete parasitological diagnosis, although we carefully reviewed. I think the bias will probably quite limited. On the other hand, we are aware that we might have missed a few cases of initial failure since we didn't have complete workup for all cases, especially in a few patients who died early. Viral load data, HIV viral load data might have been useful to better understand the risk of relapse. And of course, these results were obtained in an ideal setting with good access to care, high quality care, comprehensive treatment. We have to see to what extent this can be generalized. But overall, we were quite encouraged by the outcomes. So initial treatment response was good. Survival, keeping in mind these patients are end-stage HIV patients, was quite fair at 85%. The main issue is the relapse rate, which in our program occurred after 6 months. So longer monitoring might be useful. It's dependent on the CD4 cell count or the response, ARV response by 6 months, although we were not sure to what extent all these cases are relapse or there's some kind of reinfection involved in some. But the data support the use of ambizone at the dose we used, 20 milligram per kg, also for co-infected patients. We're not sure to what extent the dose could even be further reduced or somehow need to be increased, so there's no comparison data available. But the data also point out that we need to advocate more for availability of ambizone combined with ART or OI treatment in these settings, coupled with further cost reduction for ambizone. HIV-VL program integration might be an important issue, to have more HIV testing within VL treatment programs and to have long-term VL monitoring within HIV programs. And last topic is the issue of relapse rate, the issue of acquired resistance, which quite an issue recently, also in the field of HIV. So we had relapse cases, and I didn't show, but some of these relapses actually went on to further relapse. So this raised the issue, at least it needs to be further discussed, of the value of combination therapy or to bring in other drugs. We have now paramamycin, miltefosine, and also raised the issue to what extent we should try to use secondary prophylaxis to reduce the risk of a relapse. Thank you.